My name is Barbara Pearson, and the topic we chose for tonight is the Medicare DisAdvantage. Um, I will be the moderator. We're going to talk about Medicare DisAdvantage, and the panelists tonight are Caroline Coram and Pamela Gronemeyer, Catherine Lundowski, and Barbara Pearson. We're all members of OPS and really distressed about Medicare Advantage. So thank you for joining us for this work in progress inspired by the rapid uptick in Medicare Advantage enrollees to over 40% in 2020 and estimates of 51% by 2030. So it's very hard to generalize about Medicare DisAdvantage because there are so many plans, so many different benefits and restrictions. So we refer to kind of an average plan that follows general principles. And it's also hard because there's so much to say and we want to be as succinct as possible. So we'll either be, say, too little or too much. Anyway, for this first talk together, we're focusing on Medicare DisAdvantage from a consumer's point of view. Spoiler alert, you can see from our title that as OPS single payer Medicare for all advocates, we find the growth of Medicare Advantage alarming. However, as Diane Archer of Just Care organization, coincidentally former chair of the Board of Consumer Reports, points out, crucial information necessary to make a well-reasoned decision about Medicare Advantage is either buried or unavailable. Nonetheless, the more we consider Medicare Advantage, the bottom line for us is the clearer it becomes that if you have a choice, Medicare Advantage is not a reasonable choice for seniors. That said, many people don't have a choice, either because the principal alternatives are expensive, would take more than a third or a half even of their total income, or because their assignment to a health insurance plan is in the hands of others, well, for example, their employer or their union, or there are actually rules against it, which Caroline Coram will tell. Anyway, our first speaker is Pamela Gronemeyer. Pamela, do you want to, are you ready to start?
I'm here, I'm ready to start.
You're ready to start, okay.
Yes.
So do you want to do a little bit of a tiny introduction of yourself?
Okay, my name is Pam Gronemeyer, and I'm a pathologist in Glen Carbon, Illinois, which is in the Metro East area of St. Louis. I'm in Illinois, but it's in the Metro East. We're across the river from St. Louis. I've been a pathologist for since 1981. So I'm a pathologist. I'm a provider because I bill Medicare. I also am a recipient of Medicare since 3 years ago, and I'm also an employer and who provides healthcare for their employees. So I feel like I have a pretty broad background in the issue of Medicare and healthcare. So I'm going to talk. I'm actually just going to give an introduction to Medicare, show the background of Medicare Advantage, the definitions of traditional Medicare versus Medicare Advantage, and the current state of Medicare Advantage participation in the United States. Okay, next. Okay. I don't think we need anything. Oh, and I mean, I have some issues we are going to talk about. This are the problems with Medicare Advantage. Okay, in 1945, Harry Truman tried to create a national health insurance plan. And then actually in the early 60s, when John F. Kennedy became president, he started a commission to work on healthcare. And then he came up with a proposal that was turned down in 62. But then in 65, Lyndon Johnson was able to push Medicare into law. And we know at that time, only 60% of people over the age of 65 had insurance. Most people lost their insurance when they retired. And in addition, healthcare insurance was 3 times more expensive for people over the age of 65 than it was for people under 65. Okay, then in the 90s, they created Medicare Part C, which is Medicare Advantage. And this is was initially known as the Medicare HMO or Medicare Choice. And it included options such as prescription drugs. It included vision, and vision, hearing, and also now it's been expanded out to include home healthcare, delivery of food to people who are getting out of the hospital. And it's become a great, it's become a, well, basically what we're talking, we prefer to call it Medicare DisAdvantage, but it was created because with the theory that managed care, that insurance companies can help us manage the patients better. And as we know, I mean, I've been a physician for a long time, and I think anything about managed care, they mismanaged care. So we know that as 2021, the 63.1% of million Americans had coverage through Medicare. Medicare spending is expected to account for 18% of the total federal spending by 2028. And we know that Medicare per capita spending grew at a slower pace between 2010 and 2017, because Medicare, I mean, you can control the costs in Medicare. Okay, Part A, this is just a brief summary, which I'm sure everybody knows, but it's something that we all need to know about. And just a brief summary about why I learned about Medicare Advantage. I'm a guardian of a woman who worked in one of the hospitals that I worked in, and she wanted me to be her guardian. So when I first became her guardian, she had been discharged from the hospital and put at a skilled care facility, and she had managed care, she had Medicare Advantage. And the choices of the skilled care facilities were bad. I mean, that the point was before I became a Medicare recipient. And I realized, that this is not what we want. And I learned about Medicare, traditional Medicare versus Medicare Advantage. So when I started up, we went right in, my husband and I went right into traditional Medicare with the supplement. So Part A covers inpatient hospital stays, skilled nursing stays, some home health visits, and hospice care. There's a subject to a deductible of $1,364 per benefit period in 2019. Part A also requires co-insurance for extended inpatient hospitals and skilled nursing facility stays. And there are rules about how long you could be in a skilled care, and there are rules, and there's no long-term care coverage. Part B covers physician's visits, outpatient services, preventive services, and some home health. Many Part B benefits are subject to a deductible, and typically co-insurance of 20%. No co-insurance or deductible is charged for an annual wellness visit or for preventive services that are rated A or B by the U.S. Preventive Services Task Force, such as mammography or prostate cancer screening. And traditional Medicare pays 80% of what they approve of the bill. It's not what the provider or the hospital bills, it's what Medicare has determined they approve of it. And the patient is responsible for the other 20%. Oh, go back. Okay. Oh, no, that's fine. Go ahead. I'm sorry. Okay.
Oh, here's Part C.
Okay, Part C. Okay. Refers to Medicare Advantage. So through which beneficiaries can enroll in a private health plan, such as most of them are HMOs or PPOs, and receive all Medicare covered Part A and B benefits, and typically also some Part D benefits, which are the drug plans. Enrollment in Medicare Advantage plans has grown over time, with more than 20 million beneficiaries enrolled in Medicare Advantage in 2018, or 34% of all Medicare beneficiaries. So the next chart will show you how much it's grown. It's astronomical growth. And the biggest problem is the more it grows, the more we're going to hear that we all should go into Medicare Advantage. And I mean, in the last administration, Seema Verma was the person who was in charge of CMS, and she gave many lectures and many webinars about how we all should go to Medicare Advantage, which we don't want to go to. But I mean, it's interesting. That's what we're going to show, the pros and cons of Medicare Advantage or DisAdvantage. Okay, next one. Okay, then, oh yeah, okay. This just goes to show the permeation throughout the country, how much it varies throughout the country, in what states belong to, what residents, what states have belonged. It's 1% in Alaska, but it's interesting. They're like, no, I don't know how they have 1% because there are no Medicare Advantage companies in Alaska, and 10% in Florida, California, Arizona, and Ohio, and it's 1% in Wyoming. So it varies throughout the country. I mean, what it is. And just a little bit about Medicare Advantage. versus traditional Medicare. They estimate, CBO estimates, and Barbara said 50% by 2029. I heard 47% by 2028, no, 2029, and that's by the CBO estimate. The average cost of a Medigap plan for approval is $172, and the average drug plan that you have to buy if you don't get Medicare Advantage is $40. And also the Medicare Advantage does another thing. 56% of people don't have to show any premium on top of Part B contribution. Because if you know anything about the way it goes up as your income goes up. So while some people are paying the basic rate, if you get above $88,000, your rate goes up. Okay, next one. Okay, this is just Medicare Advantage enrollees by age and gender. And you see it keeps going up till 79. And then you start to see people, I mean, it's not dramatic, but starting to drop off. Because what happens as things occur and as you get older, and I mean, we know that chronic disease is more common the older you get, that people start dropping off because they've learned the problems with Medicare Advantage. Okay, next one. It's interesting that women are, I think, a little more likely to sign up for it. And then the percent growth per participant by Medicare type, just to show you traditional Medicare versus Medicare Advantage. Now, there are a few things that I was just going to say about Medicare Advantage that Medicare, and I didn't see these in the other slides we had, but the interesting thing is that Medicare Advantage, they claim that they're going to save money, but they also do 24% fewer tests, diagnostic tests, 38% fewer flu shots, which is incredible that they're not giving people over the age of 65 a flu shot, and 15% fewer colon cancer screening tests. The other thing that's bad about Medicare Advantage is these National Cancer Institute centers, which in my area is Siteman and Barnes, and in New York City is Memorial Sloan Kettering. None of the Medicare Advantage plans had Sloan Kettering on their network in 2018. So they're not, I mean, they're not going to the highest, the highest rated cancer care centers. And, I'm a physician, and I mean, I read the statistics and I try to pick out my medical care for myself and my family carefully. So I look at those statistics. The other thing with Medicare Advantage, we still don't know, they tout that they have better quality, but there are really no good statistics on it. When I tried to look up quality, all I could find out was profitability. So, and that is all I have to say.
Okay, thank you. So my turn, and I'm going to talk about why would we say that Medicare Advantage is a disadvantage for consumers? What advantages does it claim? Price, perks, and a biggest one is cap on spending. So my question is, do they live up to these claims? The price comparison you were just given by Pam.
I'm sorry.
That's okay. Basically, everybody does the same Part B, but the Medigap ends up being a $360 a month total for the premiums, as opposed to Medicare Advantage, which for half of the people who take Medicare Advantage, that's all they pay is the $148 or so, whatever, for Part B. And they also get, most of them get drug included. So we're talking about a difference of $200 a month. Half of the plans do have a premium, and the average premium is $63. So that brings it up to about $211. But so we're talking $200 or $360 as a difference in that part. Now, meanwhile, in terms of perks, there's no way, hands down, they put in all the perks. And in fact, and these are the percentages of plans that have them, they have the fitness memberships, which is how they got the nickname of the silver sneakers, which is included as a gym membership for you. Okay. But the out-of-pocket one is the most cited thing because people say, oh, I couldn't possibly just have Medicare because I would be I would be open to some, catastrophic amount of liability for my medical expenses. And in fact, so the traditional thing is to have traditional Medicare plus a Medigap policy. It doesn't cover everything, but it catches up a lot of what Medicare doesn't pay, and the average the average the average premium for that is about $2,500 a year, as opposed to Medicare Advantage does give you a cap. And after the cap is reached, the plan pays 100% of covered expenses. So remember, it's what they say is covered at the time you incur it. You don't always know in advance for the rest of the calendar year. And these caps have gotten pretty high. Also, if you can imagine that if you are someone for whom $200 a month, and there are people who, obviously there are lots of people for whom that's an issue, but if $200 a month is an issue, having to come up with $7,000 in December and then start again with $7,000 in January, if you just happen to have had a really catastrophic illness in December, it's not possible. So what do we have to pay to get these silver sneakers? What does the Medicare Advantage enrollee give up for these prices and these perks and having the so-called spending cap? So the first thing you give up is a free choice of doctor. You must use networks. 61% are in HMOs, and the other 40 or so are in PPOs. The HMOs have only network, and the PPOs have some out-of-network doctors that you can, or in hospitals that you can work with, but you pay more for. The benefits are not portable. The networks are mostly local or regional. The dependability of care, that's what, I mean, when, as Pam was saying, there's really, there's not a lot of good quality information. In fact, Medicare collects a lot of this information, but there's nobody to analyze it and use it for us. Every once in a while, we do get some. But anyway, just from testimonials of people, and if you go on the internet, you'll see people complaining that it's the corporation calling the shots for Medicare Advantage, and they decide what's medically necessary, and they don't have to explain the basis for their denials, and they can shuffle their networks without notice or without justification. And then you also take on the unpredictable changes yearly or even more frequently in medical planning and the possibility of getting locked in to a plan even after the providers that you joined it for may have changed or left. So the other thing you give up is transparency and accountability. We can't fit this one in. We'll come back if we have time. Meanwhile, do the benefits make it worthwhile to open oneself up to the potential abuses from networks and arbitrary administration? So on price, I think it's a yes and no. The front end costs are lower, but in fact, they have more back end costs. The perks, the drug plan alone makes it worthwhile for lots and lots of people to do it. Typically, I've been seeing that the vision plans, maybe someone can contradict me, the vision and dental and so forth tend to be a checkup and a little bit of a voucher, but not as robust a program as you might have thought you were going to have. And certainly not as robust a program as we would have in Medicare for All. But finally, in this out-of-pocket spending cap, I don't know that there is a clear-cut advantage, and I don't think there is. Medicare Advantage plan cap is 3 times as high as the average Medigap premiums. The narrow networks and the acceptance of managed care means that you're trading one leaky cap for another leaky cap. So how expensive do these bargains end up being? As it is with these low premiums, low prices, Medicare Advantage insurers make twice the margin that they make on individual and group plans. How do they make Medicare Advantage so profitable? Well, there's nothing new here. These are all the games that you're familiar with for-profit insurance using all the time. Cherry picking and lemon dropping in spades. Back-end costs, trapdoors where there's unexpected little gotcha things. Denials are rampant, and narrow networks and restricted drug formulary that is subject to change, and unexpected changes cannot really be called a cap, because you're open to being left with expenses that you must take if there's this one specialist in your area is not in your network. What do you do? And of course, the other thing they do is they just don't comply, and there don't seem to be any penalties and no accountability. There's no consumer reports for this thing, so they just don't comply. Okay, so I'm not going to take the time on these things because I know you're familiar with them, but in terms of cherry picking, you don't find any Medicare Advantage plans advertising that they have the best cancer care coverage. Okay, they mostly are trying to attract a much healthier group, and don't seem to mind if you drop when you get an expensive disease. But I guess you could have, I don't know, I'll have to take some information from people with more, with personal experience of it, but it's not to their advantage to have someone with expensive diseases. And this I'm going to show I was not aware of this, that half of all Medicare Advantage enrollees would incur higher costs than beneficiaries in traditional Medicare for a 5-day hospital stay. So graph is a little complicated, but below the line is traditional Medicare, and above the line is the Medicare Advantage plans. And by the 5th day, the Medicare Advantage enrollee is paying more than the traditional Medicare person. And by the 10th day, there's many more that are paying more. It doesn't last forever because the cap does eventually come up, but Medicare, as you know, regular traditional Medicare doesn't come in until day 60. So, and then the denial rate. So one of the things about the denials, and there's this wonderful report from the Inspector General on the behavior among the Medicare Advantage plans, that there's so much denial. And if you appeal, chances are you're going to get it overturned. So what does that mean? Does that mean they're just doing it because, well, 99% of the people they deny are not going to appeal? And if you appeal, well, you get the golden ring. So there are 7 contracts out there that they just deny everything, but they overturn. I'm sorry, they don't deny everything. I'm reading this backwards. They overturn everything that they denied, and that's just themselves. They're the 75% ones. There's another layer, and those get even more overturned. Okay, and then of course the network gaming. It's hard to find. Just Care tells us that the directories are out of date or incomplete. So there's another hurdle to trying to keep yourself into the network when the corporations are not helping you to stay in the network. And of course, they can change the doctors arbitrarily. And then that article, I see that Don McCann was here, the article where he wrote the comment for Nader's article. Nader tells about a doctor who got dumped, and his patients knew about it before he did, and he appealed it unsuccessfully. Anyway, we all know that whenever you go into a hospital, the chances of having everybody who works with, who touches you, be in your network are very, very, very slim. So, and remember that the statutory limits are on covered in-network care. That's 61% of the Medicare Advantage are HMOs. And even the others still have to watch that. So I think there is not a clear-cut winner in the cap business. And I think that those of us, that's what we're all worried about. How much can I be expected to pay? No cap on drugs. No way you can get, at this point, there's until we get Medicare for all. And there's the caps are high, but the weaseling out of the cap is what makes the Medicare Advantage so unsatisfactory. When they decide, I mean, there too, Wendell Potter has a story in Investopedia of how his mother had her hip replacement and was 2 or 3 days in the rehab, and then they decided not medically necessary, time to go home, and or pay for it all yourself. Well, that's not why you went to a Medicare Advantage plan. Anyway, bottom line, I think that just reading all the testimonials and so forth and whatever studies I could find, the quality of care, continuity of care, peace of mind favor Medigap. Medicare Advantage, the financial advantage, the cap I don't think is clear cut. But for healthy people, Medicare Advantage is cheaper and probably satisfactory a fair percentage of the time. But what's the likelihood of a senior not getting sick or not getting hurt all year, every year? I mean, there's no way to say for a given year, but you can estimate, the chance of getting a stroke, the chance of getting, and pretty soon you're up to a chance of 1 in 2 that something's going to happen to you at some point. Now, I do have some friends who have so little money that without a Medicare Advantage plan, they would just sign up for traditional Medicare if they did that, and do without a Medigap plan. And so for them, I really think Medicare Advantage is better than the alternative. But is there any reason for a person with some assets who could afford that extra amount to choose to forego real insurance, Medigap, betting that they would not get sick or hurt at an age when the statistical incidences of accidents and common diseases make it as likely as not that they will? So of course, if we had improved Medicare for all, we wouldn't have to decide between 2 poor alternatives. And that's where Catherine's going to talk. But before that, Caroline Coram will share some of the other holes in our options for healthcare coverage. So Caroline, are you there? Are you ready?
I'm here.
Go for it.
Okay, thanks. So our healthcare coverage options are full of, healthcare plans are supposed to be a safety net. I think that's the way most of us look at them, but they're more full of holes than Swiss cheese. That's part of the problem. And as you look at these, one of the big issues is that just the unpredictability and how many variations there are, how unpredictable it is, and how the person getting the same care in the office right next to you may be paying an entirely different price. And it just seems very arbitrary and very frustrating. One of the issues with Medicare Advantage is switching. If you decide it's not working for me, I want to switch back to traditional Medicare, that can be a challenge. You can always switch back to traditional Medicare. It's the Medigap coverage that you have difficulty getting. Only 4 states have laws that guarantee seniors, and I want to point out that that's seniors, people over 65, open season so that they can switch freely between plans. In other states, you have to apply for a Medigap plan, just like you would apply for any health insurance. And if there are reasons to deny you, you certainly may be denied care, or you may be charged whatever price they see fit. It's not the published prices. So they're allowed to do underwriting. And even CMS employees don't understand this, because you can call the helpline, the question, and very, very frequently you get incorrect information. They'll tell you you have a free choice, and it's not worth it. I can advance this.
I advanced. No, you have to tell me to advance it. I advanced it. It's on my computer.
How does capitation? Thanks. How does capitation work? So capitation means it's a per capita rate or a per capita fee. So Medicare pays a private insurer a flat fee to take care of you. The Medicare Advantage per capita rates for 2022, well, always these vary by what county you live in. So your community rated for people over 65, whatever county you live in the US. In the US, those rates vary from $795 to $1,844 in Nome, Alaska. And the vast majority, though, are between $975 and $1,200. So, fairly close together. Per capita rate for those with end-stage renal disease, which is kidney failure, very expensive and onerous to treat, it requires dialysis. Those are expensive. Oh, okay. I'm hearing that somebody says my sound is not better. Is that any better?
Yeah.
Yes.
Okay, I got a little bit closer. Thanks. Per capita drug costs, when you go with Part D or if it's included with your Medicare Advantage plan, quite frankly, I spent more time trying to research that than anything else. I found numbers that made it look like the per capita cost was anywhere between about $6,500 and $12,500 per participant. I'm not even sure. The data is so muddled out there. Very confusing. And payment plans are adjusted based on certain factors that affect the health status of enrollees. So for people with more complex conditions, they may get a plan may get a little bit more. There are also sort of performance bonuses that health plans can get. So those numbers can be adjusted slightly, but that's pretty close to it. Okay, next slide. Your advantage for retirees, attractive for whoever's paying for it, but it may not be the best fit for the retiree. So Medicare Advantage offers a fixed price per enrollee to provide the benefits, that what would be an out-of-pocket cost for the retiree. Generally, these are paid for by a former employer or a union very frequently. And it can be that the retiree pays a portion of it. It just depends on what the arrangement is. And it provides, that can cover the out-of-pocket portion of participating in the plan, and sometimes it covers additional benefits as well. So usually there's just one plan that's offered by the employer or the union, and there's not a choice open to the retiree. It's just take it or leave it. So this healthcare plan has a virtually guaranteed pool of applicants. They don't have to go into that Medicare Advantage plan. They could choose to pay for traditional Medicare on their own, but then it's entirely at their expense and they're forgoing some of their retirement benefits. This is kind of interesting. The American Journal of Managed Care found that the out-of-pocket spending for beneficiaries in Medicare Advantage plans was actually slightly higher than those who are in fee-for-service plans. Okay, next slide. Sorry, can you all hear me? Because I'm still seeing some comments that it's hard to hear.
It's kind of coming in and out. So maybe if you lean closer to your computer.
Maybe so. I'm not even sure where my mic is. Sorry about that. Is that better?
No.
No. Okay.
Okay, that's better.
Okay. All right. Maybe I just need to get closer. Okay. For people under 65 on Medicare, are people under 65 on Medicare? Yes. So it's basically people who are disabled. That includes sort of three subcategories: people with ALS, which is Lou Gehrig's disease, people with end-stage renal disease, and people who are disabled and have been on disability for more than 2.5 years, are long-term disabled. And that's Social Security disability when we say disabled. As of June 2020, Social Security reported that there were 8.3 million disabled workers. And an interesting statistic, 1 in 4 of today's 20-year-olds will become disabled at some point before reaching their retirement age. And that hopefully won't be long-term disabled, but they'll have some period of disability. state-to-state differences in their coverage. The rules are different for participants who are under the age of 65. Federal law doesn't require insurance companies to sell Medigap policies to people under 65. So if you're under 65, you may be able to get one, you may not. It is impacted by state law. There are actually 19 states that prohibit the sale of Medigap policies to Medicare participants under the age of 65. Medigap is not available to people with end-stage renal disease if they're under 65. Some places there may be income asset and determination limits that can vary dramatically. Some of that's going to depend on what provisions your state has in place for extending coverage to people under 65. And, you know, I've read some of the horror stories, of course, about the qualification process. And if you're under 65, it can be onerous just in terms of having to provide a continuous stream of paperwork. In addition to dealing with medical bills, you're continuously providing paperwork about qualifying for benefits. Okay, next slide. Thanks. So where does that leave people? I think we may need to go back. Where does that leave people under 65? That's the one we were on. So they can get traditional Medicare with no supplemental coverage, which is really not very realistic for most people, especially with a disability. People with disabilities tend to have substantial medical care costs. They can go with Medicare Advantage. You know, might cross your mind, well, could you buy if you can afford one, could you buy an ACA plan and have that top off your Medicare coverage? But you would have to do that before you are eligible for Medicare. You cannot buy an ACA plan after you are eligible for Medicare. In most states that allow the sale of Medigap policies to those under 65, there are no price limits on the plans, and so they can basically charge you whatever they want to. And in states that allow them, if they allow the sale of Medigap policies, there's probably, you know how you usually have a choice of, they've got all those, the alphabet soup of policies, K and N and all of the supplemental policies. There's usually only one available to people under 65. The insurer gets to choose which one that is. You don't get to choose as the beneficiary. Some states will have a medically needy pathway for people who have incomes that are moderate, but that have really high medical expenses. I mean, their income may be eaten away entirely by their high medical expenses, but those can be, again, onerous and difficult to qualify for. Okay. Next slide, please.
Can you have about one more minute? Can
okay.
You finish in 1 minute.
Okay, I'll try to speed up. Aren't those people covered by Medicaid? Sometimes yes, surprisingly often no. Only about 58% of beneficiaries who are with disabilities are covered by Medicaid. The rest have Medicare and they have to find some other way to get coverage for other healthcare needs that they have. To be eligible for Medicaid, you have to be at or, near or below the federal poverty line. The pathways are complicated because they're based on state rules, and there is a special program. There are some special programs out there, but they vary quite a bit from state to state. So that's not really a predictable solution for people. Okay, next slide.
Okay. Is that not it?
It's just one example. Jane Doe, she qualifies. Before she became disabled, she was making $41,500. Her disability benefit is going to be so high that she's never going to qualify for Medicaid because she'll have too much disability income. And so you can see you can be very moderate in income and still not qualify, even with a disability. Okay, next slide.
Oh, well, here, right.
Medicaid, state recovery, I'll just mention real quickly, you know, Medicaid is not really insurance. It's sort of a deferral of expenses because your state, once you die, your state can come back after any assets that you have, and they can take those away and try to recoup what they've spent on your health care. So.
Okay, well, thank you. So
okay,
I pulled this one back that because now it's time for Catherine to tell us about why we don't have to we shouldn't think about these two bad solutions. Okay, so Catherine, are you ready?
Sure. My name is Catherine Lewandowski, and I'm from Arlington, Washington, and I'm a registered nurse, and I work, I'm the board chair of Whole Washington, and we just put in our initiative for a ballot initiative to our legislature, so we'll be collecting signatures on that. But so that's about me. And after hearing about all of the downfalls of Medicare Advantage, what do? Clearly, we need expanded and improved Medicare for all. And again, we have a comprehensive bill in Congress where all seniors will benefit because they will no longer need Medicare supplements or Medicare Advantage. Everything will be covered without copays, deductibles, or caps. The system will benefit because we will be increasing the size of the risk pool. This helps to stabilize the whole system and brings down individual costs. Currently, we have for-profit corporations spending billions of dollars trying to lure healthy seniors out of Medicare. They are making huge profits off of them and destabilizing the rest of the system by leaving the sickest within Medicare, harvesting the healthiest for themselves. And then they have the gall to try and say that they are more cost effective. They are not. If we give comprehensive healthcare to everyone, we end up making all of our communities healthier. This reduces costs over time for everyone, as is shown by the rest of the developed nations who spend half as much as what we do, and they have better outcomes. It is well known that if you find and correct problems early, you prevent the increased costs of expensive and futile care down the road. Next slide. As you can see, these companies are not seeing much of an increase in the terms of increasing their share of the private marketplace, but they have had huge increases in their share of our publicly funded Medicare and Medicaid services. These are our tax dollars being redirected back to the for-profit insurance companies, rather than going to pay for the healthcare needs of our citizens. In the corporate world, if they do not have an ever-expanding growth, they don't get a Christmas bonus. Next slide. Many people feel that our Medicare system currently isn't really that great. It only pays 80% of hospital bills. It has limited services. It leaves out many complementary holistic treatments that have proven success measurements. The goal of our current Medicare for All fight is really an expanded and improved Medicare for All. This we know will allow our citizens to really flourish. We can take back the profits that we currently hand over to large corporations and their overpaid CEOs and shareholders. We can cover more and spend less, and then use the money we save to reinvest into our economy and our own personal budgets. Most people don't really understand what can be done when you're saving hundreds of billions of dollars every year. It's just beyond our comprehension. Things like long-term care and keeping you in your home for as long as possible. Next slide. So we have HR 1976, and that's all we need. We already are funding universal health care. We just don't get the benefits of it. Because we are taking out the middleman, we can use those monies previously given to them to pay for the health care of all the uninsured. And there's really not that many of them. We don't have to come up with any new money. We will be using money that we already are spending for health care, and 95% of all people will be paying less. Most importantly, we won't need any Advantage plan or Medigap plan because HR 1976 covers all of the services that used to require a supplemental plan and then some. Next slide. So why do we want to try and achieve single payer at the state level versus Medicare for all? And it was mentioned in our planning meeting for this session here, that the very common rhetorical question, how do you eat an elephant? One bite at a time, obviously. And truly, there have been so many issues that have been won at the state level and then go on to be won nationally. voting rights used to be only given to male landowners, and marriage equality started in a few states and now is guaranteed nationally. Just as medical and recreational use of cannabis is currently moving across the states and is expected to soon become legal at the national level, we know that at the state level, it's not as big of a lift to make real progress, especially even if you live in a state that, well, cares about its people. Secondly, achieving Medicare for all nationally is a huge task. There are still a bunch of states who really don't believe that all people have the right to health care. I am of the belief that there are elected representatives, elected by the people of their communities, who don't really believe that all men or persons are created equal, or that all people are endowed by their creator with the right to life, liberty, and the pursuit of happiness. But there are enough states that hold our foundational values near and dear to them that we know that when one state finally achieves it, that will give all the other states the confidence to also do the same. So we know that achieving wins at the state level can and will eventually lead to Medicare for all nationally, and that is our end goal. Next slide. There's always objections. Probably the biggest.
Oh, I was on that.
Oh, sorry. That's okay. I've got it minimized. Anyway, it can't be done at the state level. Medicare as a single payer, nonprofit healthcare financing system has proven that it is the most cost-effective way of delivering care to all people. And for states that already are paying for the most for their residents' insurance costs, like Washington, we only have less than 6% of our people who are not covered somehow. It's very easy for us to redirect our health insurance dollars to a more cost-effective system. And we have every right to choose the system we feel we can afford and offers the most benefits. It's called capitalism. The organization or business that achieves the best cost savings is what we choose. We are not obligated to purchase anything from the for-profit health insurance industry. The second objection that I've heard is that everyone will move to the state with a single payer plan, overloading the system and causing it to fail. Well, in my opinion, that idea just proves everything that single payer advocates have been saying for decades, that this is the best way to go. But in reality, although maybe the rich may try and move to that state, it's really tough for poor people to just pick up and move. For the poor in other states, though, any state finally achieving this will give them the strength and the confidence to demand single payer from their elected officials. And this last objection I hear occasionally, and it just really rubs me the wrong way, because you're talking about denying healthcare to your children and your grandchildren. I hear people say, I have paid into Medicare all my life, so why should those who haven't benefit or reap the benefits? And the answer to that, I think, is that it may be true that you personally have always paid into the system, but it was the middle-aged working class people who originally funded the Medicare system for their parents and has continued to fund that system for themselves and their children. And yet they have to hope that we make it to the age of Medicare in order to benefit from it ourselves. Instead of providing healthcare, it's more like playing a game of Russian roulette. Last page. We can't forget to mention HR 5010 because this is the stepping stone to Medicare for all. Bills like the state-based universal health care bill and HR 5010 will be getting a new number. It's just been reintroduced. This bill is extremely important in giving states, if they choose to, the ability to reform their healthcare systems, both for their citizens and eventually leading to expanded and improved Medicare for all across the US. This bill enables the smaller states with less ability to fund their healthcare program without having access to federal dollars from Medicare and Medicaid. This gives them the ability to access those dollars and help them to achieve the most savings. So we don't have to continue to pay for the mistakes of our parents. And in reality, I don't think that they want us to. Most of our seniors understand that the current system isn't working. And especially now in this pandemic, they see how it's affecting their children. What they most need to understand is how important it is to demand the necessary changes to fix the system. And the best way to do that is at the ballot box. Be brave enough to stop re-electing the same old politicians and expect them to fight for different policies, because they won't do it. They have shown their colors and they have no intention of changing them. If it's going to be, it's up to you and me, and we will finally achieve this together. And thank you very much for coming to our office hours today.
So I have the screen up saying thank you, questions, comments, corrections, additions from all four of us. If it's okay, I'm going to stop sharing so we can see you. Okay. Oh, there you are, Candy. I didn't see you before we started. So if anybody does have questions, would you, should we take a stack? There's so much we want to say, and there's just so much time. Not enough time to say it. So can we have, is there anybody that has a question?
Somebody. Who here?
I don't.
There is somebody. There's somebody.
Alan wants to.
And Alan. Yeah.
Hi, Barbara. So a couple of points. For single payer at the state level, the thing that 5010, and I think the new number is 20 something now, the thing that it really does is not access to the federal dollars. That's easy to get. What it does is it provides an ERISA waiver. And without the ERISA waiver, because 60% of the employer plans in the United States are actually employer funded, they don't have to comply with state law. They can just operate on their own. Without that waiver, you're not able to apply a payroll tax to employers to actually get them, to encourage them to switch over. And there's been a number of, Maryland was the last one, that tried to do that without the ERISA waiver, and they failed. So without it, the states can't do it. Now, the other thing is regarding your presentation, which I thought was really good. Voki and I found an interesting tidbit for you, is that the Medicare Advantage plans, you know, they have this flipped payment on the hospital payments that Medicare Advantage plan typically has a copay for the first however many days, 4 or 5 days or something. It turns out that over 90% of hospital stays in the United States are actually 3 days or less. And so that's a place where they take back money. So I just put that out there for you, because that's part of the trade.
One of the things I wished I could have looked up. Okay,
it's
in
our tutorial.
Regarding the ERISA, because that is true about the ERISA, but there is a way to get around it, and that's gone through this one of the courts in California, in San Francisco. So that's the language that we have. And yes, we're not able to, they are able to avoid that because of the ERISA laws. So we are not able to realize that savings, but that doesn't mean that we can't have a plan. And once the state-based universal health care is passed, then we will be able to get around those. But it doesn't necessarily stop us. It just allow those corporations, those big corporations, are able to continue doing what they have done in the past, and the rest of us can do what we need to do to cover.
According to the university,
excuse me, time. Could we have some questions on Medicare Advantage, please?
Barbara, I raised my hand. Can I get called on? It's Pam.
Okay. Yep.
Yeah. No, I was going to say that, just something about Medicare Advantage. More people don't usually go from traditional Medicare to Medicare Advantage. They usually go from Medicare Advantage to traditional Medicare. And the reason is after they've been in the hospital for a while, because what's happening with Medicare Advantage, it looks cheap at the beginning, but it's expensive at the end. And Medicare, the Medicaps and the traditional Medicare appear expensive at first. And we also know that Medigap plans vary. So and you need to pick out the Medigap plan that makes the most sense. And now they say that the F is the most popular, and G is IG. They discontinued, but you can still have it. But it was also similar to F. So I mean, there are things that you know, that, and also rural areas. I found that article about rural areas, how rural area people are more likely to switch out of Medicare Advantage because they can't go to the places that they need to go to. The networks are far away, so they have to drive many miles, and they can't get service by who's in the network. Plus, how they cherry pick people or lemon drop people is they raise copays on things like ambulance care and hospital inpatient services, so that people get charged more, so they get kicked off. Or they also just drop their doctors sometimes, just like we heard the one doctor found out he got dropped by his patients. And in St. Louis area, 2 years ago or 3 years ago, they dropped 200 providers from Medicare Advantage plans. And, then they can't say, and most of them were specialists. So that means that delays, you're always talking about how Medicare for All would delay, how it would delay our service. Well, no, it's not Medicare for All. It's because the insurance companies are playing games with us. So that's all I have to say.
So Candy Birch, who else?
Yeah.
I see Candy, I see Mary Alice. Anybody else?
Elizabeth.
I'm not sure how we really emphasize this, is that, yes, I can see that there's such an advantage, but when you go back to Medicare, then Medicare again, those prices go up. I mean, I think the problem is that the country loses out when 60% are on Medicare Advantage, and we're paying out the yin-yang for so much profit. And then we have so much more medical expenses because of the people who are the sickest are in Medicare. So I feel like, of all the things that we need to worry about, is the fact that there is such a growing percentage of people in Medicare Advantage that eventually we're all going to end up back in Medicare and there won't be any money. And so I don't know how we emphasize that, except for going to Medicare for All. I mean, that is I believe that that's the way we get out of that,
But also perhaps in the short run to try and keep people from going into Medicare Advantage,
True. And the other thing, I mean, that would be I want to say that's a scare tactic, but if you know that eventually you're going to be too sick for Medicare Advantage, are you sure that there will be a Medicare when you try to go back, even if you have to go back at a high rate? And so for me, that's a real serious issue. And the fact that the billions of dollars that are going into the profits for these people show how much money we could save. I mean, just the profit lot, just the profit things would be enough to show. If we could have true profit reports, we would see right away how much we could save.
Elizabeth.
Did I see Elizabeth?
Yes. I'd like to speak. I have a perspective of a doctor, retired now after 40 years, and a Medicare advisor, a volunteer Medicare advisor with Medicare rights. So I really see this completely. And one thing we haven't mentioned is there's a whole group of people that are totally screwed because they're not poor enough for Medicaid, and they really can't afford a Medicare with a supplemental plan. And that's why they're attracted to Medicare Advantage, because it looks cheaper at the outset. But then if you get sick, they're more expensive. They're really terrible, and they can really, and they cherry pick, like offering silver sneakers, because that only is attractive to healthy people, right, who can use a gym. So they want them. But once you get sick, they do everything they can to dump you, and they do actually. They're terrible. But there's another thing. So those people are just, out of luck. That's all I can say. They're out of luck. And I saw loads of people like that when I was a Medicare advisor. They made too much for Medicare, even in New York State, where Medicare is pretty generous compared to other states. But still, they were really up against it. And the other thing I think is very, very, very scary to me, is that if we get Medicare for all, we're going to get Medicare Advantage for all because of the influence of the industry. I think that's a big, big danger. and it scares me.
We have got to keep them out, yeah. So thank you. Are there other questions? I don't see.
I'll speak up because nobody has called on me yet. This is Mary Alice. And I just wanted to say United Healthcare is my co-insurance policy, and they're making out like bandits. They are making so much profit, and they're doing it because of the taxpayers. We as taxpayers are paying into these big companies for their administrative costs.
I was just going to say, Mary, you're right, because I saw that United Healthcare paid $5 billion in the first quarter of 2021. And the other thing we didn't talk about Medicare Advantage is the way they code their patients. You get coded by how many ICD-9 codes, disease codes you have. So they upcode people, and we know they've upcoded people because they've gotten in trouble. Aetna got in trouble for upcoding people because we know one congestive heart failure patient is not the same as the second congestive heart failure. So they upcode people, and then they plague you to death when you become Medicare age. You get millions of phone calls from companies, and then they try to pretend like they're the government. And you say, are you the government? Yeah. You know, I just kept saying, are you the government? And of course they weren't. Plus then the commercials. Like I said, I mean, my husband hated Joe Namath when he was a football player, but now I hate him when he's an advertiser because that's so much baloney, and it's just like frightening. And I mean, I just don't understand how much money they can spend on phone calls. They won't have any money left for healthcare and they've got to pay their shareholders, so they pay lots for phone bills. That's all.
Yeah. So the thing about the fraud, the fraud is so well known. And it's like, it's been for years and years, and it's acknowledged by the companies. And it's just that we can't get them to pay it back, and they keep doing it. I mean, it's a well-known thing since before 2008, I think was the first time I saw it, so that they were doing it. It's just, and it's the same thing when they do too many, one of the things that Diane Archer says, and coincidentally, she was the chair of the board of Consumer Reports before she became a healthcare pundit. We just don't have the information. There are Medicare Advantage plans where there are more people die on them. There are more people. We can't get information about how many transfer out. We can't get information about how many denials. Medicare has that information. That's the other piece of it. All these people who are getting Medicare's money, they're supposed to be making annual reports to Medicare. And a quarter of them come back with not enough information to even analyze what they've sent, as far as I can see. So they're just bad actors. What can we say? I don't know.
Mike has his hand up.
Who is this?
Mike Huntington. Can you see me?
Mike Huntington has his hand up. Oh, okay. Mike, would you call on him, please?
I call on a linguist that I know of, Barbara Pearson, and others who are skilled at messaging, and how successful negative campaigns have been and how tempting it is to villainize. I have a Warren George in town who has a Quaker background and cannot bear to spread blame. It's just against his nature. And yet we've seen the success of the anti-Medicare campaign in the late 40s. They villainized, they tried to villainize Truman. They ended up villainizing one of his cabinet members. And I'm posing that question out. Is it worth villainizing Medicare Advantage, United Health, AARP, which gets $629 million in royalties from United Health? So I'm opening that up.
So that's a really good question. But on the other hand, I think it came up in our board meeting on Sunday. We've got to do a better job of demonizing these people. They're just
it's getting not demonization, it's the truth. It's the truth.
Well, exactly.
It's not demonization. I mean, if we tell the truth, we're not demonizing and we're not lying. So they need to know the facts. because you can't get the facts on TV commercials.
Well, and that's the other thing. We get all the studies of whether it's better, you know, whether they do better on Medicare Advantage or not. They're done by, you know, most of them, when you look and see who did it, it was a consultant for the health insurance programs. Chuck, is your hand up?
It is, Barbara. Yeah, three quick things. Two I had and before, and then to add on to Mike's question right now. And that is, I've been saying this for years and years, and some people are picking up on it, some are not, is I prefer to use the term profit first as opposed to for-profit, for the simple reason that for-profit seems to indicate a certain level of legitimacy in our capitalist system. But when you say profit first, it's actually much more accurate, which is that they bake their profit into their services. They don't pay out a single service until they know they're guaranteed the money off of that transaction. So we're actually being inaccurate when we say for-profit.
Okay.
Really just absorb that for a second here, because this is an accurate way of describing what's going on, and it's fundamentally important to say it that way. The second thing is, let's invite Allison Schwartz, a former congresswoman from my neighborhood here in Philadelphia, who's the head of Medicare Advantage, onto our call, and let's just keep calling her out, because she portrays herself as this advocate for women's issues and healthcare and so forth. Let's have her come on. This is the other part, I think, of our strategy that's important, is identifying, somebody said it earlier, the bad actors. And the fact is that if you're going to be effective, you've got to identify a person. This is simply the way our media works in this country. We've got to identify the people, the culprits, who have traded in their influence, in the case of former Congresswoman Allison Schwartz, in making millions of dollars as the face and the CEO of the Medicare Advantage collective of insurance companies. And that segues into the response to Mike's question, which is, yeah, we've got to identify our enemies. However we call them out, we have to clarify who they are and what they're doing. And that's not demonizing, in my view. That's simply calling it out for what it is. And we have to be clear in our communications. And then we need to connect ourselves with other communities that don't look like us, right? We're older white people, self-identify as progressives. We need to connect with communities of color, working class folks, younger people, based on commonly shared values. We've got the same values. We might have them prioritized differently, but those are the communities that are going to help us to achieve the power to win. We're not big enough. I'm glad that I'm hearing this from other circles. This is a recognition that on a good day, we're maybe 250,000 in the Medicare for All world. Look at how big Black Lives Matter is. 225, 35 million unique participants last year. We've got to connect with these other communities in order to win. And that means that we need to connect healthcare justice with health justice. Health justice means housing, policing, guns, and so forth. I know that's uncomfortable actually for a lot of people. I've had this conversation, Mike will tell you, for 2-3 years now. But unless we connect to those communities that share our values, but not necessarily in the same order, because if you don't have a house, you don't have a roof over your head, that's going to be your focus. You're not going to be thinking about Medicare for All. You're not going to be thinking about climate change. You're thinking about survival. So we need to be more strategic. We need to connect the dots, and we need to connect our policies, our people, and our politics. And that's the pathway to victory. Thank you. And welcome everybody tonight. If you don't know who I am, Chuck Pinocchio, President of One Pair States. Thanks so much for coming tonight. And thanks for the presenters. You've done a fantastic job. Pam, Carolyn, Catherine, and Barbara. Thank you so much for your work. Everybody, thank you.
Barbara's got her hand up.
Barbara Cummins.
Oh yeah, hi. I just want to add one more wrinkle to this. The Congress just falls all over themselves supporting Medicare Advantage, the Medicare Advantage economy, let's put it that way. Every year they sign a letter begging CMS not to mess with the capitation rates. So please, I can give you the profile of your senator or your congressperson. in terms of the money they're taking from the health industry. And I'd be glad to do it. And when you go see them, tell them to stop taking this money, because that's one big thing that allows this kind of stuff to go on, the money.
So Barbara, have you seen anything about the letter this year? I haven't seen one since 2019, and I keep watching AHIP.
Right, and I've written to AHIP.
They're posting on an old one.
I don't think they're broadcasting it anymore because too many people are hip to it.
Well, but I mean, it's a good thing. We have a lot, I call it the low-hanging fruit. I have a list of the 60 or so people who had supported 1384 and signed that letter.
Right, and exactly. That's right.
So those would be people that would be good ones to start on trying to educate.
And we know now with Bernie Sanders, they don't need to take this money. They don't need it. So let's tell them to stop taking it and put it right in their face. Thank you.
Okay. So, and I don't see any other questions, or do I?
Well, I would move Barbara to share that list of senators who have signed that Medicare Advantage letter. And so we can go after
them. I have that. Yes, I have it. I'll share it.
Hey, Barbara, I was just going to say that Boomer, that I sent you that video from Boomer Benefits.
I saw it.
That's a good website. That's a good website.
Right, it certainly is. We should put it on our reference list.
I did. I put it in the chat, but it's really got a lot of good videos, and they're honest.
Well, and I actually had some of my examples on the slides that I skipped.
Right, I saw them.
But there too, it's like, what kind of data do we have? I mean, one of our old-fashioned things in saying is, the plural of anecdote is not evidence, right? But in fact, what do we have? We have first-person testimonials, and but we don't have enough of them. So I saw, there's Kay Lasker. Is on one of her ideas is to try and get little short videos where we can get a lot of anecdotes and just bombard everybody with first-person knowledge, since the statistics are so hard to get. But then when you start working on this, you say, why am I going to waste my time on Medicare Advantage when I want a 1976? But we really do have to, because that upward climb. They say, it's so popular. It's so popular because they brainwash people.
Ellen.
Okay, Ellen. Mike, I'm going to go with Ellen.
Oh, okay. Well, yeah, I just want to back on that point of, about demonizing, villainizing. Yes, we obviously have to make it clear that the insurance industry is playing the role it is. But as Warren George says, a lot of people are turned off by this kind of, rhetoric. I think there's another point to this, and that is that when we say, look at us, we're being victimized by this industry, it makes us feel powerless. And I think that by focusing more on the fact that this is a system that we as voters, that our representatives have supported, that gives us a way of saying we have power. And so that, this is a system that has been created, certainly by moneyed interests involvement in politics, but it's something that, we should sort of approach at the systemic level, and the idea that we can have new policies, that we can change this. We don't have to have profit in healthcare, that was a choice, and let's reverse that.
Yeah, actually, P&HP, I was getting materials together for Single Payer 101, and P&HP has a really nice older piece of documentation right on their website saying, if you could make a profit and deliver universal health care, we would have done it. But apparently you can't. The only way to make the profit is to restrict care.